Thank you very much for having me. Salam alaikum, everyone. It's really a privilege and an honor to be in this holy land, really, who feels like a home to all of us. I'm really not going to teach you about EOE because I don't think I can or I should. What I want to do today really is tell you what I learned from mistakes. What I also want to tell you is what is out there now that allows you and me to assess and treat our patients better. These are my disclosures, so here we are today. How common is the uncommon? And what about Saudi? Do we know? Does anyone know how many patients Saudi would have of EOE at this point? This is where I'm going to spend a little bit more time because I want to take you through the journey that I have been and that my patients have been through. And lastly, why do we need to change anything at all? I mean, things are working. EOE is not a new diagnosis, really. So let me take you through history of EOE first. So does anyone know what the meaning of EOS really is? It really is a red and the orange color when we see the eosinophil stains. Yeah, that's what we tend to see. And if you look at Eos, it's a Latin word for goddess of dawn. And I think it's very relevant because we are really going through a journey of dawn with EOE. So 1970, so about 45 years ago, we had the first case report that said it's EOE. Then 10 years later, it comes out, no, this isn't EOE, this is all reflux. Deal with it as you would deal with reflux, really. Gone past another 10 years and we said, actually, this is only a food allergy. Don't worry, this isn't a disease, it doesn't cause much problem, it's a food allergy, get on with it. 2010, ACG issued their first guidelines. So if you don't know much about this, don't worry, you're not done anything bad. Even ACG took 40 years to produce guidelines on this. British guidelines also came out. 10 years later, however, there's now an update which happened last year. So prevalence of EOE, we know that in certain Scandinavian parts, in the European part, it really is where the most of the burden is, along with the United States. Increasing. I personally don't think that it's the prevalence increasing. I think it's only that the healthcare workers like you and me are becoming more aware of it. If you could rough estimate, it's about 100 to 200 per 100,000. So for every million patients that you look after, you should have about 1,000 of EOE patients. What's the population of Saudi? It's about 35 million, yeah? There and thereabouts, 36. So as per rough estimate, you, the gastroenterologist of Saudi, should really share about 35 to 50,000 patients of EOE. Do you have it? Is that the amount that you see? I actually don't know, and I don't think that any one of us know this. Now I'm going to take you through this history to histology journey and what next. How you and I can help stratify our patients better. Can we? And to do this, I've included one of my patients who will go along the journey as we do the talk. Yeah, and I might ask you to help me with this. So 27-year-old Bassem, he was referred to me because he had a reflux for 10 years. He was been on Pentazole, taking once a day. He's a non-smoker. He had an endoscopy 3 years ago, which said you've got a lax LES that's shown grade 1 esophagitis. He had a good response to PPIs, as you would imagine. And he had no red flag. So my colleague called me and said, can you please consider him for TIF? For the audience, TIF is transoral incisionless fundoplication. It's a fundoplication that we do endoscopically. So he was basically referred for a treatment of reflux because the medications are failing. What would you do? What would be your next step? I need your help here. So what I did, I'll tell you in a minute. You can increase the PPIs to twice a day, he's taking daily. You do manometry, you do pH studies, you repeat his endoscopy because the last one was 3 years ago, or you schedule a barium swallow. Who would do A here? I did. I did that too. And I thought it was actually the right thing. So I said, I'll see you at 8 weeks. He had some improvement in the symptoms. He had intermittent regurg. And I asked him, do you have dysphagia? And he said, no. But I was wrong. I asked the wrong question, right? This is what I should have asked. If you suspect, so the first myth I want to unfold here, please don't ask if you suspect EOE in the slightest distance, don't ask your patient, do you have dysphagia? Because by the time they reach you, they have learned to live. All my motility patients, esophageal problems, they adapt. If they have wives and partners with them, ask them, is he now taking long to finish the meal than you all have on the dining table? And they'll tell you, ask them, have you changed the consistency of the food that you're eating? So that food impaction, the textbook, dysphagia, it doesn't really matter to them anymore. And we now have a validated impact tool that you can ask. The second validated tool here is this. So if you really want to do an EOE clinic, then you and your nurse should know how to stratify your patient based on the history. So at this point, we are not even taking the history properly for EOE, let alone anything else. There is a scoring system. You give them for 14 days, and at least they should fill in 8 days out of this. And therefore, if your patient has a reflux and you want to assess dysphagia, this is a kind of tool that we use in our clinic. But why reflux? Let me take you this very quickly. Why reflux is the enemy of EOE or vice versa. So there's a group of medical students in a busy clinic in the United States in 1999, patients presenting with the regurg and dysphagia. Look at the amount of GERD was diagnosed based on the endoscopy. Let me fast forward you 10 years ago, the same clinic, the same clinical presentation, the group of junior doctors did that, and half of those GERD patients were actually EOE. So it's not that EOE prevalence is increasing, it's just that you and I are becoming more aware of it. So every reflux that you see in your clinic may not be a reflux. This is how we do our reflux program, and you would see here, right at the top, and I've just squared this box for you, that's a King's reflux program. Every single patient of ours who have GERD, either the high GERD score or symptoms not responding to PPIs, they will have coordinated esophageal standard EOE protocol biopsies when they come for pH impedance. It's a standard they'll do. And then, of course, where they find on this, we send them for TIF, we send them for CTIF or Nissen fundoplication based differently. I did endoscopy for this guy, and that's his endoscopy. So all our patients, pre-TIF, I do their endoscopy, and just have a look at his endoscopy. He had furrows, he had crack lines, and I'll show you, look at this. As soon as I start to move my scope, the esophagus was want to just grab hold of it, goes into the spasm. I can't even move my scope. Yeah? This is what the new scoring system of EOE is, right? So you, as a gastroenterologist, have now an ability, based on the endoscopy, you can stratify your patients. We call it EREF score. You have edema in rings, and you have exudates, furrows, and stricture. Why is this important? Because of this. The first two, when you see rings and you see edema, are signs of inflammatory EOE. And as you move slightly next to the forward, your furrows and stricture is really your fibrostenotic EOE. And I do think, ladies and gentlemen, that from very recent future, you and I will be calling EOE two types. Inflammatory EOE is your patient have, or fibrostenotic EOE. Is that what your patient have? So up till now, we know the endoscopy can help us. The second thing is histology. So in our center, we don't really rely on eosinophil count anymore. I'm very lucky to work with my colleagues who have a great interest in histology of it, and they actually call me. They'll tell me that that's the eosinophil count, but they will also tell me about the staging. They'll tell me whether there's a hyperplasia of the cell membrane, there's microabscess, and they use the grading system. Why do they do this? Because again, the higher the histology score, and not the count, please mind my words, not the count of eosinophil that matters. It's the grading of the histology that stratify our patients. You know, you and I have patients who have symptoms, but every time we do their endoscopy, they don't have high eosinophils. And this is the reason, because we're not really, when you put them on PPIs, their count goes down, but the symptoms don't get better. And by doing the histology stratifying score, you could actually follow these patients again. So that was the histology for our patients. He's got microabscesses, he had basal cell hyperplasia, and of course his count was high. His histology score was 18, which is relatively quite a high scoring system. So how would you treat these patients? You would PPI 8 weeks, we've done that. Dietary therapy, he's already had them on, or you can give them topical steroids. So we know this is nothing new in it. We all know that's how you would treat patients of your EOE through this algorithm. However, your and my job is to look at therapeutic endpoints. We don't just want to treat these patients. We want to make them better. And treatment doesn't necessarily mean this. So how we do in our center, we stratify them due to histology, symptoms, and endoscopy. It's easy. The first one is very easy. Non-responders. The last one is easy, who has completely responded. It's the middle one that's a problem. And these are the ones where we brought a new kid on the block called EndoFlip. So all our EOE patients at King's, they have EndoFlip assessments. And if you might have heard Dr. Zahrani's talk a couple of weeks ago, a lovely talk really, because we now also have a classification based on EndoFlip assessments. So I would urge you guys to consider EndoFlip assessments of all your EOE patients. Because again, what it allows you to do, so have a look at the left side of this. Again, EOE inflammatory phenotype, and on the right side, EOE stenotic phenotype. As I said, we're not far from calling EOE either an inflammatory disease or EOE a stenotic disease. And these have therapeutics benefits for our patients when we stratify them. So you go through this HRRM, and you can see even the HRM that you got a normal. The most common you will see is ineffective motility. You wouldn't really see a lot of stricturing on this, but it does help you to stratify your patient. On the right-hand side, you can see it's either very, very hard, and the distensibly index is quite significantly low because the motility is quite tight in this. Coming back to our patient, ERF score 5, which is high, histology score 18, and that's his EndoFlip. So if any one of you does EndoFlip, every white line on the EndoFlip is a centimeter away. So those furrows that you saw in endoscopy, as soon as we stretched the balloon, it grabbed hold of it as there is a stricture in forming. So we certainly at this stage know that this patient actually had a fibrostenotic EOE, hence no response to PPIs. Moving on to the treatment paradigm shift. Can I just spend just 1 minute, just one slide on this cartoon, and I want you to understand this really, how this all works. So helper T2 cells and interleukins 4, 13, and IL-5 mediated injury. This is, we know all of, and then this introduced STAT6 and STAT5, and eotaxin 3 problem. Your PPIs, when you put your patients on, they will only act through the pathways affecting STAT6 and eotaxin 3. So what PPIs are doing, they are certainly helping with the inflammation, they're certainly helping with you some symptoms, but they are not changing either the loss of barrier or the remodeling. So progression of the journey towards and through stricturing is not reversed. So sooner or later, your patients are really going to come back for it. We now have a new kid on the block as we talk about the treatment, and this is the monoclonal antibodies that's very, very specific for IL-4 and IL-13. And of course, not only that we're seeing the results, that it reduces inflammation, does it actually reverse stenosis or the stricture? Do I really just have to dilate them? Because that's what you want to know. So let's talk about this seminal study published 2 years ago, and that looked at quite a young profile of these patients, all 28 to 32 years old. Almost 1/3 are male, and I'm sure we all know by our experience that most of the EOE patients that we look after are actually young males. What they did, so there's part A to the study and there's part B. In part A, they said, we'll give you Dupixent or dupilumab weekly for once a week, and then there was a placebo group. In part B, you had one group that will receive weekly, The other group will receive every 2 weeks, and the third group will not receive anything for 24 weeks. And after 24 weeks, all of them pretty much will be shifted to placebo. And that's the results. They were published in the data. So there were at least not only the 70% improvement in the symptoms in the treatment arm, there was 60% histological remission. This is the first time we as a gastroenterologist saw histological remission. It's like our IBD. We're not really chasing mucosal response anymore. We're more bothered on the histological. Endoscopically as well, look at the first group, 66% remission endoscopic as compared to placebo. And in the next one, when you have the placebo gone back onto Dupixent, all the ones have gone 76% response. And similarly, in the extended active treatment, recently had the third arm published, which I'm not allowed to present, but I can say it for sure. They extended it to 88 weeks now, the same study cohort. And what they did, they took the treatment arm continued, and the other arm, they put the placebo back on. And actually, the arm that went placebo back again, even after treatment Dupixent, has started to lose the benefit. And this is answer to the question, how long do I put these patients on Dupixent? So we know if you start, they get better, you stop, you do get a declining response. So where would you position a biologic? Do I give it first line? Do I put it in maintenance? Or do I really reserve it for a refractory disease? Well, the Italian guidelines only came back a couple of months ago, and they actually very happy that you could start the biologics as a first line. Should you think that this is your patient who through stratification that I've just shown you, we have at King's, endoscopic, histological, endoflip, is now reaching this fibrostenotic stage, you could start that. It's really not end of the world. How would you treat this patient now? Yeah, his EREF score is 5, which is high. His histology score is 18, which is very high. You've seen his endoflip. You give them PPIs, you give them topical budesonide or fluticasone, oral budesonide, elimination of the dairy products, or you would give them Dupixent. I think by now I have managed to convince that this is a fibrostenotic disease, and that's what we did. I started this gentleman. At that point, we did have dupilumab. We had Dupixent in October 2022 in UAE. So I had that benefit of this. And this is his endoscopy 4 months later. You remember that deep furrows of this gentleman, really? And every time I was going through, the scope was getting held by this. And at this point, there's absolutely no resistance. There's not even any hint of the stricture. So we treated him with Dupixent for 300 milligrams weekly injections. Repeats OGD has gone better, and the biopsies, distally, there was only 1 to 2 eosinophils, and proximally it's completely gone. So it works, and that was his endoflip post-treatment. So all our patients have endoflip 3 months into this. Whether we are changing the treatment, we are assessing the response, or we're not. All of our patients standard go through endoflip if we suspect they have EOE. Can I quickly go through the second case? Fit and healthy gentleman. I still remember he walked into my clinic with this barium report, and Doc, my achalasia has come back. And he's been referred to me for POEM. Could you please do POEM? Because I have had dilatations and they're not really working. And that's his barium report, but actually did say that he has achalasia. So it's not that his gastroenterologist was doing anything wrong. Radiologically, he did have barium. His story was from the 7 years. He had some PPIs. He responded initially, but not always. 2 years later, he started to get regurg and some difficulty eating. He had his first pneumatic balloon dilatation about 4 years ago, and symptom improved. He then have symptoms which are restarted. He lost 5 kilos. People who do achalasia and POEM would know we had an Eckhart score. And actually, I myself have given him Eckhart score of 10 in the clinic. And I said, yep, you have a bad achalasia. You probably need POEM. That was his blood. He only had peripheral eosinophilia. How related or unrelated is this to EOE is to be found out. And that's his endoscopy. I've actually fast-forwarded this. So what you're seeing is 3 times the speed of the video. Absolutely no movement in the esophagus. absolutely no movement. And no matter what I do here, people who do achalasia, you will see that there is rarely that I see this tight band of stricture at the GOG. No matter what I do, it will not let the scope go. And achalasia doesn't happen like this. They don't have that tight stricture. So alarm bell rang, so we dilated him. Trainees in the audience, balloon dilatation, once the balloon goes up, you pull it to the nose of the scope. So you see actually dilatation under your direct vision. And you can see at about 9 o'clock, the mucosal tear is coming. So you have a control as you dilate. And this isn't really achalasia, is it? We took some biopsies, and of course the biopsies have confirmed. You can see microabscesses there, that he had a very high histology score. It was started on 300 milligram weekly, and that's his pre and post-treatment endoscopic view. So very, very clear difference. This guy was not really for endoscopic POEM. I'm glad I didn't do it. The last part of the talk, only 3 more slides, you'll be pleased to know why the timing matters. Why am I really focusing so much on these 2 types? Because this is reversible. And if you and I don't reverse this, and the patient continues to have symptoms, with every 10 years gone past, you have given them a stricture. And the chance of that is 2-fold. So is that so relevant, the assessment of it? Yeah? And the fate is preventable. It's in your and my hand. Look at the green, which is the inflammation side, and the gray, which is the fibrotic side. As the inflammation increases, the chance of fibrosis doubles up. And every time there's a 5% increase with a year gone past of no treatment. These are hot off the press, 24-25 ACG guidelines. And I really want you to focus on the very first line, where I put the red box on. Treat inflammation and assess for fibrostenotic. So the year and a half of my life gone past telling people, bringing some assessment of fibrostenotic disease, it's now coming into the guidelines. So you should really, really assess your patients with, or at least make an attempt to assess with endoflip, because that's what allows you to see the fibrostenotic part of the disease very early on. And no matter what you do, every time you assess them in the green box, the response should not be based on symptoms alone. Please bring them back for endoscopy. Please, it's important. You take biopsies, you do histology. We also do endoflip, and that's the recommended monitoring and follow-up. All EOE patients, you put them on PPIs, you put them on budesonide, you put them on Dupixent. Doesn't really matter. But you should really reassess them every 3 months. Clinically, endoscopically, histologically, and if you have endoflip, that would help. I'd like to conclude my talk now. How common is the uncommon? What about KSA? I actually don't think it's that uncommon. I think we just don't know about it. And of course, that reflux, that regurg that keeps coming back to our clinics, we keep doing their endoscopies, is really not reflux all the time. So there is something that we're missing, all of us, including myself. Diagnostic and the management paradigm, there are challenges. Of course, not every center has got the endoflip. Not every center has got the histopathologist who would look beyond the eosinophil count. But these are achievable, and this is why you need to work locally in your centers to see what's feasible for you. It was lucky for us that we had the histopathologist and we managed to get endoflip. But that doesn't mean you can't. Endoscopically, you can stratify these patients too. And timing of the diagnosis is pertinent. It really is. Because now, you and I have an ability not to treat these patients, but to cure them, if you like. We can reverse the disease. We can track the disease in its lifetime, the natural history. We can stop it, we can reverse it. It's only about how we manage this forward. Ladies and gentlemen, I'll finish here. Thank you very much.